Hello, everybody. Good afternoon, and you're all very welcome to this webinar today on the future direction of IAPT. First of all, let me introduce myself once again. My name is Richards. I'm Director of Clinical Research and Innovation at Silvercloud Health. Silvercloud is a global provider of online mental health solutions. Today, our agenda is quite simple, and I'm not going to occupy the entire time speaking, but rather more it will be interesting for me to present some of the information I'd like to get through, but then second to that, to have some discussion and question and answers towards the end. But our agenda will follow. I'd like to present some of the recent findings around IAPT and its progress in terms of the national data set. I'd like to then discuss those findings in relation to the future development of IAPT. Where are we going? What are the elements of our 5-year plan in the NHS for IAPT? And how we then possibly can contribute to that by way of digital. I suppose part of realizing the potential of digital is optimizing IAPT, especially in the context of developments into the future. So let's begin with looking at some really key IAPT findings from the data set that would throw light and are interesting. First of all, let's begin by an understanding of the importance of IAPT in mental health service care in the NHS. IAPT founded in 2008 and has evolved ever since, and its remit is within the treatment of the high prevalence disorders, depression and anxiety, within the mild to moderate spectrum. That's what's normally considered step 2 in the step care model, and IAPT fits within that, and also then in step 3, which is more of the high intensity services. People often have a perception around IAPT that actually it's treating the mild to moderate, which are the more lower intensity interventions being used. And yes, while they are considered the low intensity interventions, such as digital therapies, such as bibliotherapy, what we also need to keep in mind is what the data is telling us. And at the moment, interestingly, the average PHQ-9 score at baseline for those being treated in IAPT step 2 is 17. This actually brings us into a moderate level of symptom severity, which is a very interesting point of note in terms of what our outcomes then are from IAPT. On a national level, the recovery rate is 49%. 49%, this is excellent if you compare that and understand it within the context of the group of people that have been treated, especially given the severity of symptom presentation at baseline. Naturally enough, with any service provision at a national level, there's variability in the recovery rate, and we do see variability, which can be wide from 30 to 70%. But our national average is 49, and we endeavour to increase that all the time, and we've seen how digital has been a key influencer and a key area where we can learn to move the needle in terms of recovery rates. So moving onwards then, in terms of some of the other key findings from our national data. And I think these are particularly interesting. I think services who are online here today who are working in IAPT and in long-term in IAPT services will find this interesting in terms of service provision. First of all, we've noticed that there's a potential discrepancy in the use of the problem descriptors, and that the problem descriptors used by PWPs are often maybe the detail of them are not executed as fully as could be. Now, that results in an issue whereby the majority of individuals entering step 2 IAPT are given a problem descriptor of either depression or generalized anxiety disorder, to the detriment, I suppose, of an accurate description for the percentages of individuals presenting with different forms of anxiety, such as social anxiety, specific phobias, for instance. So this is an interesting piece of work and an interesting thought. Now, I do know down in Buckinghamshire, David Clark, along with John Pym Servicely, have done a piece of work on this and have published a paper in respect of that work, which we'll be able to share with you at the end of this meeting. But it is worth considering how the triage is done and how PWPs are actually managing the problem descriptors to accurately make the diagnosis for the patient and accurately deliver them the intervention that's most suitable to their needs that will achieve the outcomes that's required. In addition, a second feature that has emerged from the data, and I think this is quite interesting as well, is actually all around the step care model. The step care model historically has been an empirically based model that's applied within IAPT, but applied within many other different settings of healthcare throughout the world. And it's applied because it's evidence-based. It's an empirically founded way of managing mental health and service provision. And what has been found in the data and has been reported recently by Professor Clark in the UK Forum for IAPT, is that in services where the step care function is utilised appropriately, that is, where people need to be either stepped up or stepped down appropriately, that you'll achieve a better quality of care, which leads to an enhanced outcome. Now that's really important, and I suppose it's food for thought for clinicians and service managers and clinical leads in terms of, well, are we utilising that model to its fullest in order to achieve and enhance and optimise our outcomes and quality of care? The other point of major interest in the data that has come out is in respect of the very key point of early intervention. We know for many, many years now, from many reports, of the benefits of early intervention. And now here we have the IAPT national data set also telling us something about that. That if we wait 5 weeks or longer, the chances of producing a reliable outcome reduce by 10%. That's significant. This brings us to a thought of how we manage our waiting lists, how we triage. Can we, for example, provide interventions earlier to waiting lists as a prequel to other interventions? Maybe digital interventions fit there. I know some of the work Silvercloud have done have been precisely that in facilitating the waiting list population. All of these points of information coming from the data set are now significant points of thought, significant points of interest for us to think about the future development of IAPT and how service provision may look like within the next 5 years, within the context of our NHS 5-year plan. Let's turn to that for a moment. So the NHS has its 5-year plan, and part of that 5-year plan, of course, is about the development of services. Part of developing services is knowing the points at which you need to develop services upon. We've already mentioned the problem descriptor, and this may be to do with training further of PWPs, maybe reconceptualization of how triage is approached. There are many innovative approaches here, and I've mentioned already the work of Payne Clark in terms of the recent study in Buckinghamshire. Another very interesting point, this is at a CCG level, is the idea of continuity in care. In services where, for example, a client presents and has done a triage and then they're referred elsewhere for their treatment, you have a break in the continuity of the service, which potentially implicates a lower response rate, and it implicates a poorer outcome. So anytime we can think about continuity of care will be something really good to improve on quality and thereafter on outcome. Another really interesting point, which I think is food for thought, is the number of sessions. It seems that the greater number of sessions would produce a greater outcome. Now, that makes logical sense, but it also ties in with NICE guidelines in terms of recommended dose in order to affect change. And in the area of digital provision, for instance, NICE does recommend a treatment that's 8 or 9 sessions of CCBT. I think we should be mindful of the dose required. And I know, for example, in the area of digital interventions, that it's very easy to deliver an intervention to clients and ask them to connect in with it 8, 9 times. While during that period, which may be over a 2 or 3 month period, the PWP, for example, could schedule 6 support encounters. So you're not diminishing the actual application of the session and the dose, but you're combining it with a realistic and an affordable approach to supporting these individuals as they go through a digital intervention. And of course, the other benefit is that digital interventions can be made available and are made available to clients who use them post-discharge from their therapy, so they have continual access to their account and their archives. An obvious one that we spoke about as well is the waiting times. You know, again, realizing the benefits of early intervention cannot be overstated. But another point of interest coming from the data is services where DNA rates are high have poorer outcomes. Now, this is significant. This is across the board, irrespective of the type of delivery of the service. DNA rates, obviously, if people don't attend for their therapy, they're not exposed to the active ingredients, and consequently, they diminish the quality of care and outcomes. We need to, I suppose, pay attention to that within our services. I suppose reporting within the services of DNA rates and strategies to try and come around those are some ways to try and alleviate where the problems are occurring or what areas they're occurring in, etc. I know, for example, again, this is just highlights some of the advantages of digital. I know that in services where digital services such as Silvercloud are used, that PWPs find that the question of DNA doesn't arise given the asynchronous support nature, and actually gives much more power to the clinicians supporting the individuals to schedule time that suits them, to block out diary time, etc. So a huge benefit there. Lastly, I just want to mention something that's really, really interesting and I think really important. We talk about social deprivation and reach of our interventions and trying to reach hard-to-reach populations. Well, one of those populations are people within socioeconomic strata that put them in an area of social deprivation. And oftentimes they can't, won't access services. However, what we now know is that the effects of social deprivation can be halved if we attend to the points that I've just been talking about. So ideally, the points of continuity of care when they do access services, the point of not having them waiting on waiting list extensive times, the point of giving them an adequate dose in a supported fashion, and the point of considering that when they're in service, they're not DNA, they're not dropping out. And all of those combined can reduce social deprivation and extend access and reach to those hard-to-reach populations typically. So that's wonderful. Going forward then, in account of all of this, the future, what the future holds are some of the things that the future holds that we can talk about today would include the following. We know that IAPT wants to consider follow-up. And we know that Professor Clark has named this as an important point going forward. We also know that from the empirical and research literature that the two things that support relapse prevention in the delivery of low intensity or indeed high intensity cognitive behavioral therapy, for example, are the inclusion of booster sessions over time or the usefulness of mindfulness-based cognitive behavioral therapy. Now, at a face-to-face level, that means scheduling ongoing booster sessions or appointments for clients you've seen, or indeed introducing them to a course of mindfulness-based CBT over a longer or extended period. Digital can support this really well because you can make the platform and the programs available to clients post-discharge for as long as you need. You can schedule support times at times convenient for you over the preceding or the post months and into follow-up. So it's really worth considering the utility of digital at this point in the prevention of relapse, essentially. Digital therapies have a role. A second area in terms of the future of IAPT is the clear indication that IAPT is moving into long-term conditions and is considering the utility of addressing comorbid depression and anxiety in people with long-term conditions, such as diabetes, COPD, chronic pain, etc. For a previous number of years, and maybe some of you on the webinar today have experienced this in terms of being Pathfinder sites, who have experimented with many different interventions and methods and procedures to address the needs of people with long-term conditions. We know that the prevalence of depression and anxiety is significant within the population. We also know from the empirical research that if you can address and move the needle in terms of comorbid depression and anxiety in people with long-term conditions, you can have an impact on their self-management, a positive impact on their self-management. And as we know, as clinicians and researchers and service providers, that the core to long-term conditions is self-management. Improving that will improve the quality of life of those individuals. And IAPT now are taking a stand to really try and breach that divide between service provision and the expertise that's delivered by clinicians and PWPs and the needs of those in the long-term condition community. And then lastly, the area of employment, or in the area of unemployment maybe more particularly. In early IAPT, there were employment advisors. There still are some, but over time that resource has been depleted significantly. IAPT has a role to play in this population, those who are on short-term and long-term unemployment. Because again, we have the significant comorbidity, depression and anxiety in this population at times. We can move the needle for these people in terms of this comorbidity and equip them with skills and strategies, not just to manage that, but actually to build resilience and coping and to move forward in their pursuit of increased performance, leading towards entry back into the workforce potentially. And there's some of the ways, these are the ways actually, where the future of IAPT is taking us. And we should embrace it, and we should think about digital and the utility of digital in this. In respect particularly of long-term conditions, the slide I have up in front of me now talks briefly about the prevalence of long-term conditions within this population, which is in some cases fourfold increase than the normal population. You have 30% of people with long-term conditions have mental health. In general, that's the average. And all of these, there's a symbiotic relationship has been established in some cases, or a direct causal relationship, for example, between chronic heart disease and depressed symptomology. So IAPT has a key role to play in this. And moving to the next slide, and the last one in the area of long-term conditions, it's really about the effectiveness of CBT. And CBT in particular is one of the highest used therapies in NHS and in IAPT. And CBT has demonstrated its efficacy and effectiveness in increasing the self-efficacy, the capacity to manage in people with long-term conditions. And that shouldn't be ignored, and we should actually build on that benefit. And what's really interesting here from the IAPT's point of view is delivering CBT or evidence-based therapies is what IAPT does. Bringing that into long-term conditions does not mean that the requirement on IAPT to be experts in that domain. No. IAPT, and especially, say, for example, PWPs, are experts in the delivery of the interventions they deliver. The patient or the client presenting with diabetes or COPD are the ones that should be considered as the expert in that disease domain. And that's an important message to communicate, because in our work on the ground with PWPs, there can be an anxiety around that, about moving in to support people with long-term conditions and trying to understand more broadly their needs, which is important to understand the disease or the condition they're dealing with and the elements to it. But principally, their function is the delivery of the empirical supported therapies in a way that's appropriate, and then also within the context of an alliance, within the context of a relationship, of a therapeutic relationship with the client being presented. Just to end with another slide, which I think is really important. There's a lot of movement in the space of digital therapies. It has been for several years. Silvercloud takes a thought leadership and an implementation leadership position in this area. Recently, NICE, the National Centre for Excellence in Care in the UK, has begun work in developing a protocol of review and assessment for digital therapies. Now, we welcome this, absolutely, because we want to see the digital therapies being used now being of the best quality, the best of breed, the gold standard, all of which we contribute to. Some of the key items that have been listed recently at the UK IAPT forum by Professor Clark and others have been the following ones on my slide. It's imperative that digital interventions such as Silvercloud meet NICE guidelines in terms of the content they deliver. Principally, that means that the content is evidence-based, that the solution is compliant with the governance within NHS. And in particular here, I'm referring to the IG toolkit, which is used across NHS services and which digital services should comply with. That there's evidence of the effectiveness and efficacy of the interventions being employed and deployed. And that equals feasibility studies, patient satisfaction studies, acceptability studies, right through to the gold standard in research, which includes randomized controlled trials. And they're important to witness and have that as part of the empirical base to support the implementation. Speaking of implementation, service providers, such as Silvercloud, and I'll speak about us here in particular, we should be in a position to bring to services complete knowledge around accurate and effective implementation. Accurate and effective training resources, resources for PWPs and clinicians on the ground, and ongoing updates and continued professional development as part of a package of care and a wraparound to digital service offerings for delivering effective evidence-based psychological therapies. Does it not? It needs to fit into step care. The step care protocols, integrated into effective care management of patients. And all of that should be a collaborative way of engaging with those who provide digital therapies. I know our own experience on the ground. We sit with the clinical leads, the service managers. We sit with the PWPs and the clinicians to map out and work out the best ways of delivering, the best ways of managing patients through the digital service, and also stepping them out and upwards and in different directions as the need may arise. Lastly, then, I just come to a slide where I'm just really just identifying some of the key benefits for the delivery of digital within services. And some of the benefits you'll see here, I've divided them between patients, clinicians, and the organizations. Some of these you'll be familiar with, especially if you're in services where you use digital and you've seen the benefit of digital. But if we look briefly through them, for the patient, you're talking about potentially increasing access. We've seen and have evidence for the potential of digital and Silvercloud to reach hard-to-reach populations, young men, for example. You also give a sense of control over the pace and direction of treatment to the user. That can be quite an empowering effort. For clinicians, clinicians find it's really flexible. We've seen where PWPs have been able to fit it into their diary. There's no question of DNAs. There's simply a question of I'm going on now to review the clients that I have in my caseload and doing that asynchronously. This is a huge benefit. It helps increase capacity. We've seen, for example, in services where traditionally you'd have one client in an hour session, but the capacity by doing the asynchronous enables the PWPs and indeed the clinicians broadly to increase that capacity by 6 to 10-fold, which is a phenomenal increase in terms of service provision and throughput. And given the demands placed on services, that's an important consideration. Lastly, for care organizations, it's highly scalable. Silvercloud, for example, goes on the one solution, one provider, one disorders. Now that's a huge benefit for care systems because it's not a case of commissioning multiple systems for multiple mental health conditions and multiple population types. No, you can commission one that serves all population types and all disorders, and that's really key and important. So I think just before I end and we open it up to some discussion and Q&A, I suppose what I've tried to do today is the following. We've looked at some of the more recent data to do with IAPT and where it is, and it's really interesting and enlightening some of the data around the use of problem descriptors at the step 2. I think that's really interesting. I think the second thing that's really interesting is the people we're treating. The PHQ man score on average is 17. That's within the moderate range. Our achievement of recovery rates at 59% at a national level is a testament to the efforts and a testament to delivery of high quality services already. The range of that recovery rate varies, and there are things that can be done about that. We've seen digital Silvercloud in particular introduced into services and transform services in terms of recovery rate, helping services really maximize resources to increase recovery rates and increase outputs and improve quality of patient care, essentially. We've spoken then thereafter a little bit about the future of IAPT and how IAPT is really considering moving into long-term conditions, into the comorbid depression and anxiety that's so associated with long-term conditions, and really tackling that in a bid to ease the symptoms of depression and anxiety, to increase the efficacy that the individual can have around the self-management, but ultimately, I suppose, to ease the utilization of high-cost service provision into the future. And we know that, for example, people with long-term conditions do use health services heavily at different times. And I suppose in some way, by looking at some of the underlying causes for that, including the comorbid depression and anxiety, we may be able to give some relief to that at a systemic level. The other area, of course, of importance is the area of those in unemployment, both long-term unemployment and on disability benefit, but those in more short-term unemployment. And IAPT has a role there in delivering their evidence-based interventions and also potentially delivering parallel content through employment advisors. And we know that there is a plan with the Work and Health Unit in the Department of Work and Pensions to actually integrate into IAPT some employment-based advisors into the future, which will can only improve service provision in terms of what's delivered. And then lastly, I've spoken, I suppose, in capturing all of this really has been couched within the idea of really to maximize service provision and really do the best we can in terms of providing evidence-based treatment and quality services. We should really consider the utility of digital, but only where digital has met some of the key performance indicators I've outlined earlier, that they're delivering evidence-based content, that there's a body of empirical research supporting their efficacy and effectiveness, that they are compliant with the toolkits and the governance within services, and that they also have an ongoing collaborative relationship with services in terms of implementation, in terms of training, and in terms of providing resources both for service leads, clinical leads, managers, and PWPs on the ground to support them in their use of digital, all of which are part of the wraparound services that we ourselves deliver as the leader in this area. And we're setting the bar, and we want that bar to be high, and we want to work with services effectively in doing so. So thank you very much. I'll pause there. Really happy to open it to the floor to take any questions or indeed discuss any points of interest. So I just have a question here. I'm just going to read it out I'll just try to open it up further there. Okay. So the question is, many clinicians report a high dropout on Silvercloud. What evidence is there about maintaining engagement with digital care? Excellent question. Historically, systems that have delivered digital therapies have been, I suppose, the main problem has been engagement. And the reason being for that is that if you don't get engagement, you compromise the outcome. Now, the point being made here is that engagement is important. I can tell you that both in our research and in the clinical practice use of Silvercloud in day-to-day services, that the dropout is actually much higher than any of the digital interventions to date, or the ones that we have been used in natural service provision and not just laboratory settings. I don't have the slide here now, but we've done up a recent information sheet on engagement rates within the IAPT services, and we'll be happy to share that with the group here today at the end of this call. But what you will see is high engagement rates, and actually at session 6, 7, and 8, where engagement rates are still at 50% and upwards, depending on the population being served. And that ties in very well to the recovery rates being delivered out of that engagement. Thank you. So we have a second question in now. I'm just going to read it out for everyone to see, or to hear rather. Are you planning mindfulness resources now? And if so, when are they coming out? Excellent question. Silvercloud already has quite a variety of tools for mindfulness that are available in the platform to date. Silvercloud also has a specific module that combines mindfulness tools that we have available and can make available to your service if you so wish. Each of the interventions across the IAPT suite in anxiety, depression, each of them have access to tools around mindfulness-based breathing, body scan exercises, and other more particular mindfulness-based tools, and they're available to you. Thank you for your question. So we have another question in, and I'll read it for you. You've made interesting claims for the effectiveness of digital interventions. Where can we access evidence for this? Excellent question. Silvercloud do make very strong claims around our evidence, and that's because we have that evidence. We've implemented and researched in laboratory settings and in natural service and community-based settings the Silvercloud interventions for depression and anxiety. All of the data from those research implementations we have published in peer-reviewed academic journals. All of those are available, and we will be happy after this to make them available to all attendees. We have a pack which will be easily sent out, which lists all of the publications and where they're published, and we can also provide electronic copies of those for your interest. Thank you for your question. We have another question, and I'll read it out for you too. The question is, can STAR workers support the program? If so, what level of training should be in place? I do want to do a clarification here. When someone says STAR workers, are they referring to employment support type workers? I think the asker is Ian. Ian, if you could clarify, that would be most helpful. While Ian is clarifying that in terms of the type of workers particularly he's talking about, what I can tell you is the following. We would definitely advocate that people who are using the interventions and delivering them to people are trained. Earlier I mentioned one of the key aspects of establishing digital interventions as laid down by NICE and Professor Clark as the lead of IAPT, and which are coming upon us soon, will be the necessity that providers also provide the wraparound services, including professional services for implementation and also training, ongoing training, resources for training, and continued professional development. Thank you. We have another question in. I'll read it to you. Would it be possible to have the reference for the paper regarding triage problem descriptors, please? Absolutely, that will be part of the pack that will be sent out to all of the attendees today. It's a publication last year, 2016. But it will be made available to you as part of the pack following this webinar. Thank you. We have another question. I read it to you. How long do you recommend that PWPs spend on the online reviews? Our PWPs report that these take up to 30 minutes, whereas I believe they should be 10 minutes long. How would you structure these? Excellent question. And In our experience of dealing with many different services and many PWPs on the ground, it is certainly the case that when PWPs begin to use the digital intervention, even with training, it takes some bit of time before they become used to doing the reviews. However, if PWPs are continuing to labour on the reviews in terms of occupying a large amount of the time, maybe there's a requirement then to review that. And we will be happy to engage with any service to go in and do some further training with them and further training with PWPs on doing reviews in the Silvercloud system. So please do follow up with us after this webinar. We'll be happy to engage with that. Thank you. We have another question. I'll read it out to you. NICE guidelines don't recommend CCBT for anxiety. Although we see that they're effective in service, do you have evidence, resources, papers to signpost us to dispute this? NICE guidelines recommends CCBT for depression and comorbid anxiety at the step 2. Other interventions are also recommended at step 2, such as bibliotherapy. And NICE also recommends in the use of more traditional means for the treatment of specific anxiety disorders at the more intense variety at step 3. We have another question. Let me read it to you. Have you done any research as to whether phone or online reviews improve engagement? That's an excellent question. And it's a piece of research we haven't done yet, but we will be doing. However, I will give you one story in a service where initially or historically, the PWPs were doing all phone call review. And initially, they didn't want to let go of that. They were using Silvercloud interventions and still doing reviews by phone call. It was a slow transition, but when the transition did occur, that they dropped doing the phone calls and completed all their reviews asynchronously on the Silvercloud platform, our feedback from them was, why didn't we do this earlier? This makes so much sense. So there was a real benefit to that service in terms of delivery of service. And the question specifically then of any differences between them. In outcomes, we haven't seen a difference. However, in terms of just service provision, the management of service and ease of service, and some costs, there is. Thank you for your questions. We have another question. I'm going to read it out to you. I welcome Derek outlining of the long-term conditions opportunity. Neurological long-term conditions are my area of interest. We saw the need that adaptations might be needed to make, example, Silvercloud stroke friendly. Example, videos about the process making Silvercloud LTC friendly. This is an excellent point and absolutely on point. And actually, in specific, you're working potentially with people with brain injury or maybe from stroke, as you mentioned. And a very interesting project that we've done with Andrew Bateman out in Cambridge has been the use of digital interventions in Silvercloud with people with stroke. And that paper has just been published as well at the end of last year. And I'm happy to share that with you, with the group as well. It's not a paper we'd included in the pack, but I'm happy to include that as a reference now. Certainly, in addition, in respect of your question around the customization of programs, yes, definitely. There is no question but that unless programs are customized for the population, the stickiness reduces and drops. Now, I do know of some research in the area of using online interventions with long-term condition patients. It's very limited, but there has been some work done, for example, with people with multiple sclerosis. One of the most prevalent points that came from that research was that they could not identify with the content, with, for example, the vignettes, the illustrations. They couldn't even identify with what's been asked of them in homework tasks, for example. We have recently finished a piece of work in 2016 on customizing our depression and anxiety interventions for people with long-term conditions. We've done that for the following conditions thus far. COPD, chronic pain, diabetes. We've also done it for rheumatoid arthritis, for multiple sclerosis as well. And we have one that's just been delivered in a month's time for chronic heart disease. We see these as absolutely essential to meeting the needs of the population. And not just at the therapeutic level, because, for example, there's no point in leaving the behavioral activation part, for example, asking someone to go for a run if they're dealing with chronic pain. That needs to be moderated significantly for that population. We've customized, for example, personal stories and vignettes. So we're talking about people who are the people using the program, the clients can relate to, can understand, can really engage with, can really know something of their experience and what they're going through to really make it meaningful. If it's not meaningful, then they drop out. And this is always the case with digital interventions. If I'm moving through my intervention moment to moment, unless I feel I'm being met, my needs are being met, and my therapy or the way my therapy is delivered is being responsive to me, then there will be problems. And we've done a lot of work in researching this area and customizing our interventions. And we've worked with some of the Pathfinder sites in doing this. We've worked with lead clinicians, both in clinical and health psychology, and we've worked with experts in the domain of the physical condition as well to produce these programs. The last thing I'll say about this is we will evidence-base them. We're currently running a trial. It's at 3 different IAPT sites in England. We've begun recruitment in December. We intend to recruit 140 individuals, and we intend to report on those outcomes in the coming months, because it is important that for these customizations that we also have an evidence base to demonstrate they're robust, they're best of breed, and they meet what we consider the gold standard. Thank you. I believe we have another question. I'll read it out for you. Are you going to provide other digital platforms in the near future, such as webinars? Absolutely, we will. Can I just say that in-house at Silvercloud, we have quite a range of expertise. Myself and many of my colleagues have come from an academic and research background. And Silvercloud has been born out of academic research principally, and that research was 12, 15 years long now at this stage. So a wealth of experience is built up. I hope today, for example, has been really useful for everyone that's attended. And into the future, we intend to draw on other parts and other people in the company to really, build out a series of webinars, not just on the research, not just on the latest developments, but also on the future developments. For example, we have domain experts in clinical content for digital. We will bring them on. We have domain experts in implementation science. We will bring them on. And all of that's really important. And of course, you as the audience and as participants, if you have ideas around domains of expertise or webinars that will be useful for you, please, by all means, make them known to us. Thank you. We have a further question. I'll read it to you first. I'm a little confused. Did you say that there is a high dropout rate associated with Silvercloud? No, there is not a high dropout rate with Silvercloud. In fact, the point I was making earlier was the opposite. What we see with Silvercloud is that the work we've done around adherence has paid off. And what we're seeing is a much greater level of adherence and stickiness to the interventions, which of course has a direct clinical benefit to outcomes. Thank you. I've just got a comment there from Ian, the participant who we spoke about earlier regarding the STAR workers. They are workers within employment support. And Ian, just to address directly then, everything I said in respect of training and Silvercloud providing that training is appropriate to answer your question. Thank you. We have another question. Let me read it to you. Are you aware of any clinical settings where Silvercloud has been combined with physical therapies? Okay. I know that we've had quite a number of requests from different domain specialists, such as physiotherapists, to use it. I also know um, that we are used in settings which are outside of the NHS, and those settings are multidisciplinary settings. So while there's an opportunity in those settings for Silvercloud to be used with a wide variety of patients in different specialisms, such as physiotherapy, I can't say for certain, and I don't have data to support it at the moment. We have another question. Let me read it for you. Could you possibly tell me something? Sorry, pardon me. Could you possibly tell me about some of the upcoming programs in development at Silvercloud? Will there be any kind of, the scrolling, program developed for trauma? Excellent question. I suppose two of the principal areas that are going to be coming up in the next 12 months and are of particular interest to Silvercloud, and actually services that we deal with are asking for it. One is around substance abuse, which is very broad and is yet to be, we need to determine more specifically what areas will be useful. The second area actually is in the area of trauma broadly. And we're interested, one, in stress and acute stress, especially for frontline staff. And secondly, we're interested in PTSD. And we've done some initial spec and scoping with that with Professor Deborah Vidal out of Florida University, who's an expert in PTSD. But that's where we've got to so far. We would really welcome you or your comments, pardon me, on areas where we might pay attention to in the development in both those domains or indeed wider afield. And please feel free to send us suggestions. We'd be more than welcome to look at those and engage with you on those. Thank you. We have another question. Is there any feedback on whether phone calls boost engagement while using online platforms, or do these patients prefer only online content? That's an excellent research question. It's not a piece of research we've carried out formally as yet. There is, however, no evidence to suggest the superiority of phone calls in supporting people on Silvercloud over supporting them in the asynchronous manner. Our data from NHS sites that we partner with would show equivalent of outcomes, irrespective of whether they're supported by telephone call or by online. As a caveat to that, I will say this. I do have data that shows a small marginal improvement in outcomes for Silvercloud with asynchronous support from the platform compared to telephone delivered bibliotherapy. Thank you. We have another question. Let me read the question to you. Is there more data on the effect of is there more data on the effect of what is on reliable recovery, say 4-week wait or 6, 7, 8, etc. wait? You mentioned 5-week wait has a 10% reduction. Yes, this is an excellent question. And again, it speaks directly to the benefit of early intervention. The earlier you can provide an evidence-based intervention for someone who's volunteered or has been referred through service provision, the greater the benefit. The data I presented was data aggregated from the national IAPT data set, which showed, and we just did this basic analysis, was done and it was delivered in the recent UK IAPT forum, that if an individual is waiting 5+ weeks, you diminish the potential for a reliable outcome by 10%. Now, logically, that should obviously increase exponentially if the wait is longer. And this again goes back to thinking about waiting lists and really reimagining what can be done. I know some services we work with, for example, both at step 2 and step 3, provide all of their users with Silvercloud as a first point in step care, while they're waiting even for their other type of options such as group therapy or bibliotherapy or indeed more high intensity. And actually, on that note, I will say this. We have another research study which is in the middle of recruitment in the southwest of England. And what we're looking at in that research study is delivering silver cloud interventions as part of a package of care at step 3. And I think the results of those will be particularly interesting because the net effect of delivering it as part of a package is precisely to eliminate the waiting list. Thank you. I believe we have another question. Let me read it to you first. Would Silvercloud consider a program specifically for professionals, supporting them to manage their own mental health given the demands of services? That's a wonderful, wonderful question. And certainly, all of us as clinicians, people involved in service provision and working with vulnerable groups, we're human too. I would always, and I've said this time and again, for PWPs or clinicians, advocate for them to use the programs. The content in the programs in Silvercloud are at the highest quality, the highest evidence base. I know we've come across it as clinicians in training, and you're thinking about it from the point of view of delivering it. But there's also the noted benefit of thinking about it in terms of implementing it in their own lives. In addition to that, something more tailored for the professional, certainly I believe there's a possibility for that. And I would welcome whoever did ask that question or others that may be interested, please contact me, because what we could do is maybe start thinking a little bit more about that. Thank you. We have another question. I'll read it out. Is Silvercloud planning to develop any adapted material for use with children and young people's IAPT? Wonderful question. And actually, this is a very, very interesting area. For the benefit of the listeners, I will say this, that Silvercloud have already developed a significant resource called Include Me. And we developed that over 2 years with the Anna Freud Centres. And this intervention is used in many of the IAPTs, the young people services. CAM services, my apologies, which are now children and young people. And it's essentially a resource that's used within session. It has tools for shared decision making. It has tools for mood monitoring. It has other tools of that nature. And also it has tools to collect data on the minimum data set type measures. In addition to that, Silvercloud are engaged in a much larger project with some key people in the national office in IAPT in developing out and contributing to the development of children and young people services, and of course particularly the digital side of those service provision. And that's an ongoing project. But again, we've been in consultation with many key players on that, and we will welcome any clinicians involved in that area to contact us and work with us on developing those services. Thank you very much. We have just a comment to say thank you, great work, and I really appreciate your thanks. Thank you. Another question, and I'll read it out to you. Is there any evidence on how soon the reviews should be offered and how best to space them over the treatment? You know, that is a wonderful question. And different services have implemented a different type of support protocol. I have seen, for example, some services who allow users to use the program in a very flexible manner, and they deliver support on a fortnightly basis. Some deliver it on every 10 days. Some deliver a schedule of support which culminates in 6 review points over an 8-week period or a 10-week period. The variation there's wide variation. Whether we have data to support which way should be implemented, right now we don't. However, I bring this question back to our data analysts and to see if they can dig down into the data we have from natural service provision to determine, is there a difference based on the type of support schedule delivered. So thanks for the question. Okay, I mean, I think that was wonderful. Thank you very much for all your participation. I really appreciate the questions. They're really food for thought. I hope that you've all enjoyed it and have been able to get something out of the webinar. We're here online. Communicate to us by email. We will send out a pack with some resources that we've discussed during the webinar also. We look forward to future meetings with you and others, and thank you very much for your time. Bye for now.